Hello guys, this is Gary and I'm going to walk through an echocardiogram, adult echocardiogram. Alright, you can lay down on your side there. All the way over. So initially I want to set up the patient. I can strip that out. I want to set up the patient, make sure that they're comfortable, make sure that they're covered and feel private and safe and all that stuff. And then I'm going to perform a standard echocardiogram, which is initially the peristernal long images. I'll capture that, and then I'll zoom in and show both the aortic valve and the mitral valve. I'll do some color, and I'll make sure that the gains are appropriate for the valve image I see. Same thing, I'll zoom in a little bit on the mitral valve, then I'll come back out. Next thing I can do, it depends on the institution, but you can do mitral and aortic valve and left ventricular M mode. So that would be an M mode and capture that screen. This would be an M mode of the mitral valve, and then this would be an M mode across the LV. Many institutions don't do that anymore because we can have such clear two-dimensional pictures. So then I'll do my LV measurements. And so this is across the right ventricle, this is across the septum, this is across the posterior wall at the diastolic point of the cardiac cycle, and this is across the systolic portion. Now I'm going to do my measurements of the valves in the left ventricular outflow tract. So let's put this across and see a two-dimension of the LVOT. And let's do a aortic sinus. And then let's do a left atrium. So that's pretty good views of the peristernal long axis. Now I want to switch over. I'm going to go to a appropriate sized right atrium, right ventricle, and tricuspid valve picture. Got my two-dimension. Now I'm going to go to color. And I showed the color. You can see that there's a little bitty wispy part of tricuspid regurgitation, which is physiologically pretty normal. And let's still get a gradient if we can. If I can't get it in this view, I'll get it in a different view because it's so small and wispy. But initially, it should be around the 20 millimeters of mercury point. Now I'm going to go to a peristernal short axis view, and I can see pretty clearly that this is a 3-leaflet normal morphology aorta valve in the center. I'm going to move from right to left. So first I'm going to look at the pulmonary artery, get that in two-dimension, black and white 2D, and then also get it in color, and then also get it in a Doppler signal. Normally, in a full exam, I would trace all of this out and see what the signal velocity is, duration. If there was enough PI, which I don't see a lot of PI, maybe physiological, but really not consistent. If there was PI, I can do an end diastolic velocity as well, but really not in this picture. This is a zoom in on the aorta. This is the color of the aorta, and that looks pretty good. There's no leaks or anything interesting there, no stenosis, sclerosis, very normal looking valve. Then I'm going to go to the tricuspid, or move across the screen to the left side of the screen, or the right heart, and show again that that wispy, tiny little bit of tricuspid regurgitation that's hardly there. My numbers, I can still get my numbers. It's going to be around 18, but that's not a complete envelope really. Maybe able to get a little bit better when I get to the apical long views. Now I'm going to shift a little bit more south on the heart and see the mitral valve in short axis. You can see the papillary muscles, and now that I have the valve, I'm going to put color on it. I'm going to zoom into it a little bit. I'm going to capture that, I'm going to see if there's anything that's interesting. The hardliest, tiniest little wisp of MR we saw earlier, we can see on the posterior leaflet. It looks like the tiniest little jet. And then we're going to go a little bit further south on the left ventricle. This is mostly your wall motion views, mostly your coronary artery questions about if there's an adequate supply, or if there's anything that's a regional wall motion abnormality, anything along those lines. And I march all the way down. I'm taking several pictures as I get all the way to the tip of the left ventricle. So that's a pretty quick walkthrough of the of the parasternal views. And then now I'm going to shift and reposition the patient to make it a little bit easier to see. And I'm going to go down to the apical views and find a window. So this is a reasonable window. You can see pretty clearly. I'm going to re-evaluate and set up all of my focus, set up my my view to maximize scale, all of these things. So now I'm going to focus on all 4 chambers. This is a 4-chamber apical view. Next thing I want to do is I want to zoom in and start asking questions about these chambers in order. So I typically start with the left ventricle, and from the top right picture, but it's the left ventricle, and I go to a diastolic view, which is the largest volume view of the left ventricle, and I'm going to walk through and do a Simpson's tracing of the left ventricle during diastole. And I want to go from the hinge points of the mitral valve all the way to the other hinge point on the other side of the mitral valve when I do that tracing. And I have the same anchor on my apical systolic view, which I'm doing now. And I come around and I avoid, the thing is to be consistent. So if you're going to cut off all of the trabecula in the left ventricle, consistently do that across the board unless your cardiologist is instructing you to do something different. If you're consistently going to not measure these trabecula or these parts of the papillary muscle and things like that, make sure that you are tracing consistently, and then you can be advised by your own cardiologist or your own group that you're working with where you want to put the border of the endocardium. Okay, so if it's a clear picture like how this is really nice and clear, pretty easily I can figure out where the boundaries are, and you want to just be consistent, because then you can fine-tune based on input from your cardiologist. Okay, so the next thing is I want to do is I'm going to change the scale a little bit. I'm going to come down to the mitral valve, and I'm going to do a Doppler. This is a pulsed Doppler of the mitral valve. I'm going to make sure that I have appropriate scale on the Doppler signal. That's a big thing, is if you're going to measure a Doppler, make sure that you're utilizing most of the available real estate to do the measurement, because the smaller the Doppler signal is on screen, the more likely you are to mismeasure and make because of a scale issue. It's not that you didn't get it at the right place, it's simply that you didn't have the appropriate scale. So there I was measuring the E and A of the mitral valve, and also I measured the deceleration slope so that I could figure out some of the diastology later. Now I'm going to go to the TDI, which I can come back and forth on updating this. And you can see the small window in the top. I can move my Doppler, and I will place that on the lateral mitral valve annulus. That's where I have that little window. And now I'm measuring the E wave on the E prime on the mitral TDI. You can also zoom. Here's a choice too. You can zoom down when you're doing TDI. So I'm going to do the next TDI with a zoom just to show you. And what I'm doing now is, again, I'm placing this directly on the medial annulus, the center annulus of the mitral valve. And this is going to show me my E prime. Okay, so I'm measuring the E prime. And that has to do with, this is a young candidate, a young patient So this would only really be useful information when the heart is less compliant and there's diastolic dysfunction, something along those lines. But I measure it just for this video. And then the next thing is I'm going to go to a zoomed picture of the left atrium. And when I'm doing this, as I'm tracing out the left atrium, and I want to start on the far wall, on the distal wall. And also I don't want to include all of the atrial space, because the mitral valve can be inappropriately added to the volume. Okay, so I want to make sure that I'm going from annulus to annulus on the screen. I'm going to show that it's going from annulus of the mitral valve to the other annulus on the other side of the mitral valve, and I'm basically cutting off that mushroom cap. I'm cutting off the top of the mushroom so that I only am seeing the stalk. Okay, only seeing the atrial space that is really atrial, versus some large dome that was created from the mitral valve during its full space, just prior to diastole. So the next thing is I can zoom, and these are maybe extra measurements that aren't always necessary. I can see the pulmonary veins. I can see 3 separate pulmonary veins at least. I can see one there, and I can see one there, and very likely this is one over here, right? So these are all pulmonary veins. If I were asking a question as if this patient were a transplant, they'd received a transplant heart or something along those lines, maybe I'm interested. If they are part of a mitra clip, they have had a significant mitral regurgitation, and then they had a device added to close that regurgitating valve. We call that a mitra clip. Then often we have to measure the pulmonary vein velocity. So I can see this on screen. It's not the clearest picture. I could probably tune this if I had more time, but I'm not just trying to do the whole video of everything super long. So basically inside this is the Doppler signal for the pulmonary vein, and I can measure the velocity, and I can measure the duration, and I can get more information about the patient's new heart, their transplanted heart especially, and learn if they are in early rejection. So the next thing is I'm gonna shift gears and go to this view, which is called an apical 5. It's not really 5 chambers, it's really a vessel. This is the aorta valve in the middle, and this is the aorta coming out of the left ventricle. And what I can see is, if I turn color on and I save it in black and white, so I have these 2 clips, then I can see there's no regurgitation, I see there's no stenosis as far as a 2D evaluation, but also when I go to my Doppler signals, I'm maximizing my pulsed wave to make sure I get a really good velocity and a good tracing. I always do a VTI. It's not required to do a VTI. A lot of people would just like to put a velocity, and if it's a normal valve, they don't add this measurement. But I like to do it because maybe potentially in the future some challenge will happen to this patient, or maybe this we could reference for research, and you want to have this as their baseline. So I like to do a VTI pretty much across the board on every single patient that I see, so that it can be used as a reference later in their healthcare, or if it's a masked or blinded research study, then they can utilize that data. So I almost always trace, and this is now the continuous wave of the normal atrial aortic valve. Okay, so that's pretty much why I do that. Now, special occasions, if this patient had some kind of pericardial effusion, they had fluid around the heart in some way, then I would want to do Doppler of the mitral inflow, and I would slow down my sweep an awful lot, so it would look something like this, and I'd speed it, bring down the speed. And the patient, you don't make any kinds of comments, you don't have a conversation with the patient, and you don't do this when they're agitated or irritated or in a hurry, because you just want them to be peacefully breathing, as reasonable as possible. Sometimes this is in a hospital bed and they're already stressed or agitated, but you just want to have normal breathing for at least 4 or 5 cycles, so that you can see the undulation of the breathing changing the velocity because of the pressures and such. Okay, so that would be telling me if their pulmonary, if their pericardial effusion was significant, or hemodynamically worthwhile to comment on. Okay, so that's why you would do it. If it's actually tamponade, that's your question. So now I'm going to go over to, since I've already done the 5-chamber, usually I will zoom up and I will show the entire right heart, so I can see the right heart function as far as the systolic and diastolic function. You can kind of two-dimensionally assess that. I'm going to switch over to color, and I'm going to switch again to this glorious little wisp of tricuspid regurgitation. It's hardly anything, but I'm going to get a good signal, because you don't want to bring a patient back when the physician says, what was the RVSP? Okay, make sure that if you can at all do it, do an RVSP, do a reasonable, make sure that it's a U shape, make sure that it's a reasonable Doppler signal. You can slow it down, you can max it out. You want to show more than one signal on the same screen. That's preferable. So it's preferable to have 3 in a row. If I can get 3 in a row. 1, 2, 3, 1, 2, and as part of the breathing cycle and coaching, you can do that with the patient too. So I sometimes, if it was a critical piece of information, then I would coach, or have the patient hold their breath, or whatever it is, to basically have in the window the TR jet and have it not moving, right? But I've got 2 and 2.5 really good, nice signals, and I can see that it's consistently in the range of previous measurements. I see that before it was 22, now it's 18, before it was 19. This is a really normal range, okay? So the next thing I'm going to do is I'm going to switch over to a two chamber view, is what we would call it, which is, this is the left ventricle, and this is the left atrium, this is the mitral valve. And on the inside, after I do my 2-dimension, I'm going to switch to my 2D. I'm going to switch to color, and I can see again this tiny, small, minor regurgitation of the mitral valve, and document that. Now I'm going over to an apical long view, or they call it a 3-chamber view, and sometimes I'll zoom again. If it depends on what's curious about the image. If it's curious because of wall motion or coronary artery disease, the person had an MI, they had an odd abnormal EKG, something along those lines, then I want to make sure I document well on all views what's happening with the left ventricle, because that's what most physicians, cardiologists or not, are interested in. They're mostly interested in the pumping capacity, the ejection fraction, these kind of questions. So you make sure that you have good endocardium, good view, good picture, right? And the secondary concern, especially in young patients, is regurgitations or stenosis or whatever, because almost it's very rare that that's going to happen. Now I'm going to ask the patient to be flatter so that I can get reasonable subcostal view windows. And it depends on the patient. This patient is a good candidate, excellent resolution, very, very good pictures for ultrasound, so they're appropriate. Some patients are pregnant, some patients are obese, some patients, they just are super annoyed about getting pushed on their stomach. So you have to measure how much effort you're going to put into getting the answers. Most of the time, what physicians are interested in, slowly breathe in for me. Most of the time, what they're interested in is this view, which you can see, hold your breath, which is basically their vena cava, breathe normal. So if you can get the patient to, you can see it really earlier, but I coached the patient, and if they are COPD, emphysema, they're chronic smoker, they're, whatever it is, they may not be able to hold their breath very long. So you need to time well when you are going to ask, and time well when you're going to acquire the images. Normally, most of the time, we have these on a beat-to-beat kind of cycle where it's going to capture 2 beats. So if they are a bradycardic heart, if they are basically taking a long time in between heartbeats and you ask them to hold their breath, sometimes it may take a long time before the first QRS. And that long time is time that they are starving for air, they think that they're going to pass out or whatever it is. So time well and gauge appropriately based on the patient. Slowly breathe in again, big breath in, big, 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 full, 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 full. Hold that breath right there, don't move. See where you went. So there's the vena cava again, right? Breathe normal. Now you should do a sniff which is yeah, you have him snort, and he did this. But sometimes, and also on the short axis, while we're here, sometimes when you're doing the sniff, just remember the easiest coaching you can give is mimicry. So the best thing to say to the patient, especially if there's a language issue, or especially if there's, you know, some kind of elder patient that isn't following you as fast as you're wanting to speak or anything like that, is just to say, hey, in a moment I want you to copy me. I want you to do exactly what I'm going to do. I'm going to snort, and I want you to copy me when I tell you. If you will instruct them and take the time to instruct them in that way, then you'll get a really nice sniff. It'll happen when you're asking for it. It'll happen within the 2 or 3 second loop that you were doing. So you won't have to recoach and recoach, because so many of my students, I do see that they made the attempt, but the timing of when the loop actually captured misses the collapse of the vena cava altogether. Okay? So I hope this was helpful. This is my video of a adult normal echocardiogram. If there were disease status or anything along those lines, such as a coarctation or a stenosis or something that was above and beyond, then I would have done a suprasternal view. If they had a significant aortic stenosis, I would have done maybe a right heart, or I would have done PEDOF to basically measure the peak velocities on the aortic valve. And yeah, so this is a reasonable, this is probably about 80% of your population. This is what's necessary. The ones that have medical challenges, or they have heart transplants or left ventricular assist devices, these are going to be one-offs or less often. And you should ask your physicians at your practice what it is that you need to do. Okay? So I hope this is helpful, and I'll follow up in a different time. Ciao.